so much. Before I get started, unfortunately, I'm sorry, Jerry, I have another compliment for you. So when I was organizing grand rounds at the University of Michigan a year or two ago, I asked Keith Aronson, our director for heart failure transplant, who we should invite for heart failure, to give grand rounds, and I got one name and one name only, and that was Jerry Estup. So I mean, I think that I would just second Dan's comments as a leader in the field of heart failure. It's great to hear that you still think that trying to reduce infarct size is a priority, which is good to hear. All right, so here are my disclosures. Overview and learning objectives. We're going to talk a little bit about predictors of outcomes in STEMI, which actually could be a whole talk unto itself, but just essentially focusing on things that could potentially reduce the likelihood of poor outcomes for STEMI patients that could be targeted with SSO2 therapy or supersaturated oxygen therapy, mainly infarct size, microvascular obstruction, and microvascular dysfunction. So when we're thinking about outcomes for patients with STEMI, there's definitely different buckets. Some things, patient factors, age, their comorbidities that they're coming to us with that have accrued over many years. And then there's presentation factors, so some of which are related to the patient factors, but how long did they wait until their, how long did they wait with their symptoms before they came in? I know that we've talked a lot about Georgia Bloom times ad nauseum, and data here and data there, depending on how sick the patient is. It takes them longer to get to the cath lab. We know that. Treatment factors in terms of what is the quality of the care that the patient's receiving, some of the technical factors in the cath lab, and some of these are things that we can really target and try to improve the outcomes for our patients. And some of these things, at least at this point, we don't have the technology to be able to reverse the patient's age, are not necessarily considered to be intervenable. So we do know from prior studies, and I think that this will be discussed in additional talks today, so I won't go into it in great detail, that we do know that supersaturated oxygen therapy reduces infarct size after anterior MI. And the reason that this was FDA approved for this indication is because the FDA recognized that infarct size has such a significant impact on patient outcomes that they accepted that as the outcome and approved the therapy. So increasing infarct size, as we actually, I think this is the same figure that we just saw, is associated with poor outcomes. So the greater the infarct size, the worse the patient does, and that makes complete sense to us logically. But ultimately, we do know that sometimes even when we get the blockage open with primary PCI, that we still don't have a good clinical outcome. The patient, either continues to be hemodynamically unstable, or they have a pretty significant infarct size. So why does this happen? So we think that this is probably happening largely due to microvascular dysfunction. Obviously, you're going to have some cell death, but in some circumstances, we may still actually have some cells that might have been viable, but we lose them due to impaired microvascular flow. And this can happen from a number of different reasons. It can be mechanical or functional, and I'll kind of go into that in a little bit more detail in the following slides. We do know that microvascular dysfunction is associated with adverse outcomes post-PCI in patients with STEMI. In this particular study, this is actually a meta-analysis, but typically we've defined microvascular dysfunction for patients with MI as an IMR greater than 40, which is different from our cutoff in stable ischemic heart disease, where we would usually use 25. And we can also quantify microvascular obstruction by cardiac MRI. This is some work done by Suzanne Duwaha and her group. It's published a few years ago. And essentially, using MRI, we can see that there's got the orange sort of rim. That's the hypo-enhanced area of microvascular obstruction, and then the hyper-enhanced area is the remainder of the infarct area in the yellow. So we can actually do some quantification by MRI. And so, just to kind of think back, I know this is really reaching back for some of us, thinking about capillaries are very small, typically just created, of the endothelial cell, and then the endothelial cells have these tight junctions under homeostatic conditions, but our red blood cells need to pass through these little capillaries in order to, get to the tissue and actually have an oxygen exchange across the capillary wall. So there's lots of opportunity there for things to go awry. So how does no reflow and alterations of the microvascular bed actually happen? This is actually an older figure, but I think this really nicely summarizes all of the different things that can happen. You've got your capillary lumen. You can actually have endothelial swelling, endothelial blebbing into the lumen that can actually obstruct blood flow. You could actually have external compression of the capillaries by the swollen myocytes. You have microemboli, which is something that we think about. You can actually have rouleau formation from the red blood cells. Of course, we have other things like neutrophils and fibrin and platelets, all of which sort of consort to impair blood flow for our patients that we're trying to restore blood flow to. So there's a lot of different things that we're actually struggling against as an interventional cardiologist that we can't even see. As far as the pathophysiology, as I just explained, all of this results in reduced cellular energetics and impaired oxygen delivery. And then, of course, in the midst of all of this, we have cells that are dying, releasing ATP and ADP into the extracellular space, and that actually sort of perpetuates all of this platelet activation, thrombosis, and inflammation, which just makes things worse. So ultimately, what we're trying to do is obviously restore blood flow and try to keep our sort of capillary bed and our endothelial cells happy and provided with as much blood flow as we can. So the microvascular obstruction, we do know that as I showed in the prior study with MRI, by MRI has been associated with increasing infarct size. So the more microvascular obstruction that you have, the bigger the infarct size you will have. And then, of course, the increase in the mass of the microvascular obstruction is also associated with poor clinical outcomes. So how does supersaturated oxygen therapy actually work? It's been looked at in preclinical studies as well as in some sort of translational studies. But what we think is actually happening is reduced endothelial and myofibril edema, increased oxygen delivery, and possibly a paradoxical reduction in oxygen-free radical production, which is probably the thing that comes to mind for most of us. We think about oxygen, we think about patients with ARDS, and they're, we're told we don't really want them to get a lot of oxygen, but perhaps we do have kind of a sweet spot with this particular therapy in terms of having it be transient enough that we can actually restore some of the mitochondrial function and actually preserve some of the microvascular flow. So this is just some data from the preclinical models when they were calling the supersaturated oxygen intracoronary aqueous oxygen, demonstrating that this actually did better than just sort of even the auto reperfusion, meaning like just allowing the blood flow to come back, or active neuromoxemic perfusion. So it's not just the sort of flow that's actually improving it, it's actually the oxygen content being higher that actually was what improved the myocardial flow. So just to summarize, we do know that microvascular obstruction is associated with increased infarct size and poor clinical outcomes in patients with STEMI. Most of that work has been done using MRI, and that we do know that microvascular obstruction sort of occurs through the process of endothelial swelling, neutrophil plugs, and platelet aggregation. And we do know from our preclinical work and from our clinical work that supersaturated oxygen reduces infarct size in patients with large myocardial infarctions, particularly those presenting within 6 hours of symptom onset, and that supersaturated oxygen does improve microvascular function in preclinical studies. So thank you very much.
So we do have some time for some questions. Anyone have any questions? Maybe I can ask a question to you or to the panel. MVO is getting a lot more attention in the research area in interventional cardiology. And I'm just wondering if you can make a comment about, if anyone could make a comment about techniques for assessing MVO in the lab. Obviously, we can use MRI, but that's not helpful in kind of a therapeutic window. Can you maybe tell us a little bit about what's happening in the research area and whether some of these techniques might make it into clinical practice?
So right now, the main option for invasive microvascular function testing is using correlated system, because Philips is working on revising their system at the moment. So that would be the way to do it. As well, you'd have to have it integrated into your cath lab, and actually it's very straightforward. You essentially just put the compression wire down. Ultimately, you could use that same wire for an intervention if you wanted to. The current protocol does use adenosine, and so I think that would be something that would have to be sort of further evaluated or sort of thought about as maybe in the QMI setting we might want to do it without adenosines. But yeah, I'd be interested in hearing what others say, but I think that it would be very feasible to do it. I just think that we need to have more volume and experience and opportunities to do it. So.
Anyone else want to comment?
You know, I think that is exactly right. Forklift is really, I think, the only real option that we have currently. And I was just going to add, as all the interventionists know, sort of the poor man's assessment of microvascular obstruction is how is that myocardial flush after you open the vessel. So the example that you showed where it was the epicardial artery was open, but the blush was terrible. So in that case, you know that there is a lot of microvascular obstruction. I think in the real world, that's probably our best signal, but not a good one.